one of the main things that usually is a common thing that all of us hear about is kidney failure or renal failure. So what we call end-stage kidney failure, when you talk of end-stage kidney, you're talking about basically chronic kidney failure or chronic renal failure that most likely will require kidney replacement or renal replacement therapy, like kidney transplant or dialysis, hemodialysis. Those are what we call renal replacement therapy. So either you do dialysis or you do a renal transplant, you replace the kidneys. So when you talk about end-stage kidney, in end-stage kidney or renal failure, the sclerose, that is basically glomeruli become hardened, sclerosed. And then the tubules, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, they become atrophic, atrophic, they become small if you have to look at them under the microscope. And then in the interstitial, that is between various cells, there will be fibrosis. Well, basically, there will be that healing by formation of fibrous tissues like a scar. So there will be fibrosis. But macroscopically, that is looking, if you have to look at the kidney that has failed, macroscopically, that is grossly, under the naked eye, the kidneys will be small and firm with symmetrical thinning of the cortex. If you look at the cortex have become thin and poor demarcation of cortex from medulla. So you don't see a very clear demarcation between the cortex and the medulla of the kidney. And then the glomerula are replaced by a vascular, a cellular hyaline material, we call it hyalinization. So the glomerula will be replaced with time by a vascular. Vascular means there is no blood vessels. A cellular, the cells can hardly be identified. So that's what we mean, a vascular, a cellular hyaline material, what we call hyalinization. And then there is what we call thyroidization. Tubules are dilated with casts, resemble the thyroid follicles. That is why it's called thyroidization. So if you look at them, you'll almost think that they're thyroid follicles. I think we talked about thyroid gland in anatomy 2, probably. So they look like that. So the tubules become dilated with casts, resembling the thyroid follicles. It's called thyroidization. So in end-stage kidney, also the excretory function of the kidneys are lost. Acid-base balance cannot be maintained. So basically the function of the kidney, that is to do ultrafiltration, will be affected. The acid-base balance, basically you're talking about the urea, creatinine, talking about the things like potassium, that balance is lost. Yeah. And then the endocrine function of the kidney are disrupted. That's what we call erythropoietin. It's a kind of a hormone that is produced by the kidney, and it helps stimulate production of red blood cells from the bone marrow. So that function is lost. Yeah. And these are some of the main causes of end-stage kidney. These are some of the things that can lead one to develop renal failure, end-stage kidney. Yeah, end-stage renal failure. Things like diabetes, which is not well controlled. Yeah, things like glomerular nephritis. So in this case, of course, the glomeruli are affected. They're inflamed for whatever reasons. It doesn't have to be infection. There are many causes that can cause it to become inflamed, and finally fibrosis and so on takes place, and they end up failing. And glomeruli is where the filtration takes place. Also hypertension, high blood pressure. If it is not well controlled, as we said last time, hypertension, just like diabetes, affects especially the small blood vessels. So if you don't control, finally even the blood vessel that is going to the kidneys end up being affected. And so the kidney end up not getting enough blood supply, and necrosis is likely to take place in the kidney, and they may end up with end-stage kidney or kidney failure. So there is what we call basically glomerulonephritis, and there are different types. There are very many different types, but all of them tend to have mainly the same pathogenesis. So in this case, there is one we call acute diffuse proliferative glomerulonephritis. So acute diffuse proliferative glomerulonephritis. So from the name, of course, acute diffuse is basically affecting almost the entire kidney. Proliferation is cells are like increasing. There is a sort of cells increase in cell number at that point. Proliferation, glomerulonephritis. So if you are to look at under the microscope at a kidney that has acute diffuse proliferative glomerulonephritis, the kidney, there will be an enlarged hypercellular glomeruli. So the glomeruli will look like enlarged and hypercellular. That means it has a lot of cells. There seems to be cell increase in cell number. There will be infiltration by neutrophils because basically inflammation. So there will be neutrophils, and because it's acute, mostly in acute inflammation, mostly neutrophils will be the one that will predominate, and then the capillary lobes will be obstructed. So it's what we call endocapillary. That is basically within the capillary. The pathology will be happening within the capillary walls. That's what we call endocapillary. And this one, acute diffuse proliferative glomerulonephritis, is most commonly occurs in children and often follows a streptococcal throat infection. So it tends to follow an infection of the throat by a bacteria we call streptococcus. So streptococcal. So that's why it's very important for children, especially if they have a throat infection, they have sore throat. It's important that we treat it well, because actually it can end up causing problem with the kidney and causing glomerulonephritis. So if you to look at it, you see that there will be glomerular swelling and proliferation of endothelial and the mesangial cells. So it's good to remember back the histology that we had looked at. There was the mesangial cells. So they will tend to swollen and proliferated. So there will be proliferation of endothelial and mesangial cells, and there will also be glomerular swelling. Then the capillary lumina are blocked by cells, but the urinary space remains clear. So in this case, the lumina of the capillaries will be blocked by the cell because there is increase in that, there is proliferation of those cells. So they make it narrow. The lumen tend to be narrow and even blocked. But in this case, the urinary space, that is after filtration, the glomerular space will still be clear because there is no proliferation of epithelial cells within the glomerular space. And of course, this one will lead to diminished glomerular filtration and causes leakage of erythrocytes. The erythrocytes are red blood cells. Those they leak into the urinary space. And usually present with hematuria. Hematuria is blood in urine because there is blood leaking. Usually, red blood cells should not be filtered. They should not usually be filtered, but in this case, they are filtered. And so somebody is likely to present with hematuria. That is basically blood in urine, or blood-stained urine. And they're likely also to develop transient hypertension. Transient hypertension is hypertension that is not really permanent, that will just be there, and it is slowly, if the problem is sorted, it disappears. So that's what we mean by transient hypertension. And also there will be edema. I think we talked about edema in the previous, in pathology 1. That is basically acute nephritis. And then granular deposits of IgG. IgGs are antibodies, immunoglobulins G. So there is granular deposits of immunoglobulin G, IgG, and complement on the glomerular basement membranes and in the mesangium. Remember the mesangial cells. I think there is that anatomy that we have looked at. You need to go back on it so that you can understand. And may rarely occur in what we call SLE. SLE is a systemic lupus erythematosus. Systemic lupus erythematosus. It's a kind of autoimmune disease. As we talk about autoimmune disease, basically the body forms antibodies against its own tissues or its own cells. So it occurs sometime in a patient with systemic lupus erythematosus. So that in itself may lead to acute diffuse proliferative glomerulonephritis. What we call nephrotic syndrome. When you talk about a syndrome, mostly you're looking at, there are many signs or symptoms that form maybe a specific or point to a specific condition. So in this case, when you have what we call nephrotic syndrome, you have marked proteinuria. Usually you shouldn't lose proteins. You shouldn't filter out proteins. Three benefits. So mostly in the case of a nephrotic syndrome, you have proteinuria, that is protein in urine. So if you have to do urinalysis and examine the urine, you will see a lot of proteins. And that is what we mean by proteinuria, that is protein in urine. So there is marked proteinuria, there is hypoalbuminemia. When you talk of hypo, is low. If you talk of hypokalemia, is low potassium. Hyponatremia, you're talking of low sodium. So when you talk about hypoalbuminemia, it is low albumin. And albumin is one of the proteins. Yeah, so there is hypoalbuminemia, and that is generalized edema. There is hyperlipidemia, that is high cholesterol in blood in nephrotic syndrome. So it's an important feature of several kidney diseases. So many kidney diseases, you have to check the urine is likely to have that nephrotic syndrome picture. They're likely to have proteinuria, albuminemia, and so on. So in the case of nephrotic syndrome, the glomeruli are damaged, and then the permeability of the basement membrane increases, and that is why it allows a lot of this protein to go through the albumin, the protein, and then there will be edema and all that. So the glomeruli is damaged, permeability of the basement membrane increases, then plasma proteins pass through into the filtrate. And one of the things you need to note is that albumin is the main protein that is lost. So that's why we have hypoalbuminemia. That is, albumin within that will be low. Then proteinuria, there will be a lot of protein. If you have checked urine, there will be a lot of loss. So mainly that protein will be albumin. Yes, so there is a diagram showing how nephrotic syndrome develops. So it starts with the glomerular damage. So the glomeruli are damaged. Plasma proteins and fats infiltrate. So it goes, the proteins are filtered into the filtrate. Also the fats are filtered there. And so when you do that, when that happens, you have reduced plasma osmotic pressure. So it's good to go back and look at the way edema forms basically. So there'll be reduced plasma osmotic pressure. And that in itself leads to edema. Yeah, so, and then edema, you will have reduced renal blood flow. So when you have edema, the blood flow through the kidneys or the blood supply to the kidneys tend to reduce. And then you have what you call renin secretion. So usually the reaction to the kidney will be to produce what we call a hormone called renin. And this hormone, what it does is to increases reabsorption of water and salt. And so when you end up absorbing a lot of salt, usually water will tend to flow. And then, of course, there's a vicious cycle. And if you do that, there's likelihood of reduced plasma osmotic pressure, then more, the edema even gets worse. And the cycle, if nothing is done, that vicious cycle develops. It's what we call nephritic syndrome. So remember, there's nephrotic syndrome, then this is nephritic syndrome. So this one is acute onset of hematuria. So in this case, there is acute onset of proteinuria. There is also proteinuria. There is hypertension. There is edema. And then there is oliguria. Oliguria is a decreased amount of urine. So somebody will be passing a little urine. Usually, I think the usual amount for urine for a human being should be around, if you have to calculate that, around 0.5 ml per kg. Yeah, per hour. So if you want in 24 hours, you multiply by 24, you can talk about 1 ml per kg per hour. That is in the normal adult. That is the amount of urine that you should produce in 24 hours. So if you talk of oliguria, it is the amount of urine in 24 hours is less than normal. Yeah. So when you talk of no urine at all, you talk of anuria, A-N-U-R-I-A. Anuria is no urine production. Somebody is not producing. Oliguria is producing less urine. So there is edema and oliguria following an infective illness about 10 to 20 days earlier. So 10 to 20 days earlier, somebody would have an infection. Then later now they start developing hematuria, proteinuria, hypertension, edema, and even oliguria. So usually the edema is caused by glomerulonephritis, acute. So usually it will be acute and rapidly progressive. So the proteinuria in nephritic syndrome will be more direct. Remember in nephrotic, we talked of marked proteinuria. So there will be moderate amount of protein within urine in the case of nephritic syndrome. So there is water, sodium and water retention, just like in nephrotic syndrome. But the edema in this case in nephritic syndrome will be mild as opposed to the nephrotic syndrome. So edema usually affects loose tissues mainly. So it affects the loose tissues mainly. So around the face, the eyes, the ankles, and the genitalia. Whereas in nephrotic syndrome, it will tend to be generalized. The edema will tend to be generalized. So in this case, mostly it affects around the face, the eyes, ankle, and genitalia. So that's where you find the edema in nephrotic syndrome. Then there is an important concept called diabetic nephropathy. We say one of the things that can cause injury to the kidneys and even renal failure would be diabetes that is not well controlled. So diabetes, either type 1 or type 2, if it's not well controlled, it will affect the kidney. Indeed, diabetes will affect any part of the body. Wherever blood vessels are will be affected. So in the kidney, is what we call diabetic nephropathy. Diabetic nephropathy. So in this case, if you are to look at that kidney that is affected by diabetic nephropathy, you will find diffuse and nodular glomerulosclerosis. When you talk of sclerosis, you're talking of hardening. So that glomerular become hardened, they become sclerosed, the arterioles become hyalinized, there's what we call capsular drops, fibrin caps, thickened glomerular basement membrane. So that's glomerular basement membrane, so it becomes thickened. So among the early glomerular changes is uniform and homogeneous thickening of the glomerular capillary basement membrane. Later, there is increase in mesangial matrix. Remember the mesangial cells that we looked at? So there is what we call acellular Kimmel-Stiel-Wilson nodules. So we can nodular diabetic glomerulosclerosis. So that one you will call it nodular diabetic glomerulosclerosis. Diffuse diabetic glomerulosclerosis, we have mesangial matrix increasing, diffuse, increases diffuse, and global. That's the one you talk about, diffuse diabetic glomerulosclerosis. So mesangial matrix will increase in a diffuse manner and global. That is affecting the entire glomerulus. Then there is escape of plasma in diabetic nephropathy. There is also escape of plasma protein across the thickened but leaky. So although the basement membrane is thickened, it is leaking into the urinary space. So fibrin caps are inspissated protein deposit on the outer surface of the glomerular tuft. So capsular drops the inspissated proteins on the inner surface of the Bowman's capsule. Of course, there will be proteinuria also. It's likely to have nephrotic syndrome. As we are saying, nephrotic syndrome is likely to be present in many kidney conditions. Also, chronic renal failure, there will be chronic renal failure. There is likelihood of ascending infection leading to acute pyelonephritis. So sometimes actually it may be ascending infection. We are referring that infection that is in the bladder that goes ascend through the ureters and gets into the kidney, and so finally causes pyelonephritis, which is infection of the kidneys. And then there is arteriosclerosis of the renal arteries and their branches leading to renal ischemia and hypertension. So those, I think we talked about arteriosclerosis last time when we talk about in pathology too. So of course, when they become sclerosed, those renal arteries tend to narrow. Yeah, and so this one will cause ischemia because very little blood will be getting into the kidney. And also this may lead to hypertension. And this may eventually lead to chronic kidney disease. It's not a common, basically diabetes is a common cause of renal failure. And if you go to a big hospital where they do dialysis, in fact, we do it dialysis here in Bungoma County Referral Hospital, you'll find majority of the patients, they had diabetes that was not well controlled. They ended up with chronic kidney disease that requires dialysis. Then the acute pyelonephritis. So now we are looking at infection. So as we said last time, when you look at any organ, you need to think of conditions as congenital, inflammatory, maybe tumor, cancers, infections, metabolic, iatrogenic, it can be traumatic, or even vascular. So of course, trauma to the abdomen, you can easily injure the kidneys. You can have traumatic injuries of the kidneys as well. But you have infection. So when you look at infection of the kidney, there's what we call acute pyelonephritis. Acute pyelonephritis, which is basically the inflammation of the interstitium. And when you look under the microscope, you see neutrophils will be a lot of neutrophils. Therefore, prominent neutrophils, especially in the tubules. So if you look at the walls of the tubules, you see a lot of neutrophils. And they may be even abscess formation. So abscess is accumulation of pus. You can have an abscess within the kidney if you don't control this infection. So if you look at the pelvic system, there's what called pyelonephrosis. So infection around there, call it pyelonephrosis. And then around the capsule, there may be perinephric abscess. So around there, the abscess may spread to around the kidney. So around the capsule, we'll have what we call perinephric abscess. Yeah, just below the capsule. But mostly in infection, you find that the glomeruli are usually spared. That is, mostly they are not affected by the infection. But with time and repeated episodes or persisting infection, the renal parenchyma becomes permanently damaged and is replaced by fibrous tissue. So if the infection is not controlled or treated appropriately and promptly, then eventually you end up actually affecting the entire kidney. So eventually even the glomeruli will be affected if there is the treatment is not done and there is repeated infection of the kidneys. And then, so eventually, of course, the features are of end-stage kidney with loss of glomeruli as well as tubules. So finally, if you don't control it, it will affect the entire kidney. Even the glomeruli end up being affected because there will be fibrosis, and that fibrosis will end up affecting every part of the kidney. So they usually follow ascending infection from the urinary tract. For example, in benign prostate and BPE, benign prostate enlargement or benign prostate hyperplasia, it could be hyperplasia or hypertrophy of them. So in males, you have enlarged. So if you have an enlarged prostate that is blocking the outflow of urine from the urinary bladder, so you end up with a lot of urine within the bladder, and this may eventually affect that valve mechanism of the ureter as it enters the urinary bladder. And so you end up with what we call reflux. So the urine will end up refluxing back through the ureter and goes all the way to the kidneys. And this usually will cause the infection within the kidneys. And this may be complicated by the development of papillary necrosis. So chronic pyelonephritis. In chronic pyelonephritis, if you have to look at a kidney that has a chronic infection, the kidney will be, mostly it will be scarred. There will be scarring of the kidney. But one thing we say, most of the time, the infection that gets to the kidneys is from ascending. That is an infection that is from the bladder going up through the ureters into the kidney. But sometimes the infection may be blood-borne. That is, you have a general infection within your blood. And because there is blood flowing, of course, through the kidneys, because it has to be supplied with blood. So blood, actually, infection can come from blood. If you have sepsis, infection within the blood, then it's likely also to cause pyelonephritis. And usually, just like in many conditions, if you have infection, they're likely to be fever. That is high body temperature. You're likely just to be sick, that's malaise. And you're likely to have loin pain. That is basically the pain around where the kidneys are. I know all of us should be able to know where roughly the kidneys will be located in your body. Yeah, that will be called the loin. And then we look at tumors. So one of the very common tumors, there are many tumors that can affect the kidney, and one of the very common one is called nephroblastoma, also known as Wilms tumor. So you'll see them calling them Wilms tumor. It's the same thing, nephroblastoma. And if you are to look under the microscope, mostly in such a tumor, there will be primitive and differentiated cells. Primitive and differentiated cell is, they will not look like the kidney cells. They are undifferentiated cells. And mostly they like also to form what appears like tubular structures. So it's an important malignant tumor. So it's a malignant tumor in spite of the name that appears stoma. You know, when you talk of nephroblastoma, it will appear like benign. You talk of lipoma and so on, but in this case, it's malignant. So it's an important malignant tumor in children and infants. So children and infants, less than 10 years mostly. And it tends to be more common in the first 4 years. So a child between 1 year and maybe 4 years or earlier is more common in that age, but mostly less than 10 years. So it is thought that is of embryological origin from embryonic renal blastema. So it is thought that it could be originating from these embryonic cells, the blastema. And that's what we call nephroblastoma. So occasionally you have structures that are resembling immature glomerular are also found. So sometimes you look at it and you see structures that appear like glomerular that can be found. And usually tends to be unilateral. That means it mostly tends to affect one kidney or one side only. Yeah, of course it can occur bilaterally also, that is affecting both, but most of the time it tends to be unilateral, that is affecting one side or one kidney. And it tends to have an early blood spread to the lungs. So metastasis, it tends to metastasize early to the lungs. It tends to be through blood, that is hematogenous. And clinically, signs and symptoms, somebody is likely to have hematuria, that is blood in urine. So when they urinate, there will be some tinge of blood in it, or it may be, frankly, bloody. And somebody is likely to develop hypertension, and somebody is likely also to come with abdominal pain. And in this case, of course, there will be children, because as we said, it's common in children. So there is what we call also renal cell carcinoma, RCC, renal cell carcinoma. Is the most common primary malignant tumor of the kidney. And this one usually is derived from the renal tubular epithelium. So it's the epithelium of those tubules. Remember the tubule, there is the proximal convoluted tubule. We have the loop of Henle. Then we have the distal convoluted tubule. So it tends to occur from those epithelium of those tubules. And the great majority tend to be sporadic. Yeah, so there seems to be a confusion there. So it should be the great majority are sporadic. That is basically they occur without any, you cannot pinpoint and say it is more common in this area or the other, or in such this population or another population. So it tends to be sporadic. And then we have subtypes of renal cell carcinoma, like the clear cell, papillary, chromophore, collecting duct, sarcomatoid. So those are just subtypes of renal cell carcinomas. So talk about clear cell carcinoma tends to break the walls of intrarenal venous tributaries. So those tributaries, the veins within the kidney itself, intrarenal, that is inside the kidneys, and to grow as a solid cord along the lumen of the renal veins towards and into the inferior vena cava. So it tends to follow those veins as it goes back all the way sometimes to the inferior vena cava. Yeah, so how does a patient present? A patient who has renal cell carcinoma, remember it's affecting the kidney. So there's what we call a classical triad. When you talk of triad, you're talking of three. So the patient is likely to present with hematuria, that is blood in urine. They're likely to present with flank pain, that is the loin pain, pain around where the kidneys will be located. And then you are likely to have a palpable mass. That is, if you palpate the abdomen, if you feel the abdomen with your hand, then you are likely to feel a mass within the kidney. So hematuria, flank pain, palpable mass, that is the classical triad. That is classical, but most of the time this may not present classically. Somebody may just come with hematuria with no flank pain, with no mass, but it probably will still can be renal cell carcinoma. So you either have any of these, so it may present with all of them. It can be one or more of these. Yeah, so you are likely to have more of these also, of either hematuria, flank pain, palpable, all of them, or one or two of those. Then you are likely also to have anemia. Remember, when the kidney is affected, then there was the erythropoietin that stimulate the bone marrow to produce red blood cells. So if you don't have that working properly, then you are likely to have anemia, decreased red blood cells. So you end up with a low hemoglobin level. Of course, just like any other cancer, you're likely to have weight loss. You're likely also to have fever. So fever is not necessarily always infection. It can occur also in renal cell carcinoma. So we can also have venous emboli, spread tumor deposits to the lungs. So there is sometimes embolism. Remember, it can spread through mainly the veins, and it can go all the way to the vena cava. It goes back to the heart, and even goes to the lungs, producing typical isolated, what we call cannonballs secondary. So when they're in the lungs, there's what we call cannonballs secondary. So remember cannonballs. So there will be some opacities within the lung. Many of them can be isolated. Renal adenocarcinoma also has a propensity for metastasis. So this renal cell carcinoma can also be called renal adenocarcinoma. Also has a propensity for metastasis to the bone and brain. So it has also a risk of, it can go to the lung, but it has also a propensity to spread to the bone and even the brain. So it tends to be more common after 50 years of age and mostly in males. So if you are to look at the male to female ratio, it's 3:1. That is for every 3 males, there's 1 female. So 3:1. So it's more common in males. So they often tend to be small and maybe multiple. So the causes mostly are known, although there is an increased incident in cigarette smokers. So they have found that from research, they've seen like they tend to be more increased in people who smoke, but largely the causes are not known.